kind of learned that if you can think of something that'd be cool to have for like technology, like it probably exists. Somebody thought of. All right. What is the only time when you go on red and stop on green? The only time you should. When eating watermelon. I know we're not really in watermelon season, it's pretty cold, but. What did the mom chameleon say to her nervous kid on the first day of school? Don't worry, you'll blend right in. Nice. What did the firefly say to his girlfriend? You light up my world, I like that. That's good, I like that. You look simply glorious. All right, corny one, super corny. All right, some of the topics that we cover in this class are tough, very tough. I know that some of you have personally had wrestlings with some of these nervous system disorders. Obviously we talked about concussions. In a class this size, probably a handful of you have had a loved one or has a loved one wrestling with Alzheimer's disease. It's a relatively common disease. Doesn't make it any less or any more simple to deal with. Then we transition and we flip the page over to cancer. Okay? And most all of us have had cancer impact us in some way, shape, or form. Whether it's immediate family, whether it's extended family, or whether it's close friends. Okay, so it's tough to kind of turn the page into some of these topics. And then for me, my mom passed away from cancer. So I'm kind of opening this section recognizing that we're going to talk extremely scientifically with zero emotion about this topic. And I don't want you guys to translate from that we're taking out the human element, okay? But understanding sort of what cancer is, how it comes about, and then talking a little bit about how we treat. As healthcare professionals and as researchers or scientists as you move on, this is not a disease that's likely going to dissipate. There's not a vaccination for it. These are our own cells that mutate. And we'll talk about those mutations that take place. So there's variations that happen in the genes. So this, unfortunately, is here to stay. We're getting better and more sophisticated and smarter about how to treat, but it's tough. It's actually, I think, especially challenging for individuals that know kind of just enough to be dangerous when you have a loved one that has a disease. What I mean by that is you know just enough about what's going on to worry even more. And you can look stuff up and now you're like, oh crap, I really hope it's not that. You guys following me? So you just have to be a little careful because, none of us are experts in this field, including myself. This isn't my area of research. But when Mom was struggling with cancer, I pulled out all the stops. My best friend from college, my college roommate, he's an oncologist. He's a cancer physician now. And we hadn't spoken in a few years, and so when Mom was diagnosed, I was on the phone with him like almost every day. What about this drug? What about this drug? Do you have any clinical trial data on this drug? And it can become all-consuming, right? So we're going to dive into terminology. We're going to dive into cancer topics, and I just want you guys to recognize that, if there's a point where maybe you just need a break in any of these topics because it's just too much, I get it. Just slip out the back, okay? Hopefully that won't be me. All right, see you guys. Need a break. Okay. All right, that being said, what is cancer? Right? Fundamentally, again, this is a general biology class. A general pathology class, not a general biology. A 300 level general pathology class. So you can imagine that we can do 2 semesters at a graduate level on cancer. Right? And there are a lot of more highly qualified researchers at this institution that can be teaching you this lecture. because that's what they actually study cancer for a living. But I want to sort of just introduce you all to what cancer is, and we'll talk at a basic level so you have some basic understanding. And it may just help you explain to some of your family and friends as you move on through life about what the different terminologies in cancer refer to. So really what it's referring to is uncontrolled cell growth. So if we look at the cell cycle, we know that there are certain points at which we hit the pause button. And we hit the pause button to check the integrity of the DNA so that we don't replicate something that is been transcribed or translated incorrectly. And I was actually listening to something on NPR just the other morning, and a cancer specialist came on the air and said, do you realize how many cancers all of us experience on a daily basis? Potential cancers that our body actually fixes before they become problematic. And that is absolutely correct, and we're going to talk about some of those. Probably won't get to it until Wednesday when we talk about tumor suppressor genes. Okay, so our body is designed to deal with mutations or aberrations, but we're supposed to catch them. We catch them and we correct them before they replicate. That's the way it's supposed to work, but it doesn't always work that way. And so when we don't catch it, we don't correct it, and they replicate, we get uncontrolled cell growth, and that's a cancerous mass. It's growing essentially out of control. So you can see this schematic where we've got on the sort of the left side of the schematic, your left over here, we've got normal, and then we've got a dysplasia, and then we move from left to right, we've got a neoplasm, and then we've got what we call an invasive neoplasm. And so what are the different definitions? All right, so a dysplasia, that first change, that's a term that means malformation. Something is malformed. It is different than what it's supposed to be. Okay? And then we've got this in situ neoplasm. And a neoplasm is a new growth. Okay? A new growth. Neo meaning new, and plasm referring to a growth that's taking place in the tissue. And when that neoplasm gets out of control and starts breaking out of its normal boundaries, then it's considered to be invasive. And it's going to migrate. And that's when it becomes dangerous. And so we talk about neoplasms in two big categories. We talk about benign, and we talk about malignant. And in the benign stuff is usually the messaging where you get the phone call and the doctor says, okay, the pathology came back, and I've got good news. It looks like it's benign, right? Now, the patient still has cancer, but it's good news in the category of, right, aggressive natures. You guys follow? Malignant's the one that is not good news. And malignant means that it is metastasizing, it's breaking off, and it's going into other places. Okay, so let's take a peek here at, I think, a very helpful chart to explain and compare and contrast the differences between benign and malignant. All right? So on benign, we've got on the left side of the slide, and then malignant we have on the right side of the slide, and we're looking into the reproductive system of the female. And you can point out on this particular slide that we've got a benign lesion in the endometrial region of the uterus. And if you characterize what that lesion looks like, it's slow growing, it's got a low level of mitosis, it has well-defined borders. And what exactly does that mean? Well-defined borders. Anyone want to take a stab at it? You can see the edge. You can see the edge well. So if you were going to come in here and surgically remove it, you would know exactly where to cut. right? You could cut it out surgically and take it out, and you'd have a high level of confidence. You know, if I went maybe 2 centimeters beyond where that edge is, and took a little bit of healthy margin or healthy tissue, I'd feel pretty confident that I got the whole thing. So that's a benign lesion. It's very well defined. It's non-invasive, so it's not invading other tissues. The cells themselves are considered well differentiated. So this is a term where they look like the cells that they're within, the tissue that they're within. So they're going to look like smooth muscle cells of the myometrial lining, the muscle lining underneath the endometrium. And so if you look histologically, they look like smooth muscle cells. They're well differentiated. They look like skin cells if it's a benign lesion on your skin. Okay? If it's in the muscle, they look like muscle tissue. If it's in the liver, then it's well defined if it's benign, and it resembles hepatic tissue. Make sense? You're not worried about metastasis. You're not worrying about stuff breaking off and going downstream. And classically, we don't necessarily refer to this as cancer. It's called like pre-cancer. We might watch it if it's not surgically easy to get to. If it's anywhere on the skin, it's a benign lesion. Oftentimes they remove it because it's not worth risking. Okay? Even if it's in an aesthetic space, they might consult with the family and say, well, yeah, you can have a little bit of a scar. We can send you to plastics, and maybe they can touch it up later. But with your history and your family, it's probably smart just to get this out of the way. Okay? So that's benign, right? Correct? Left side of the slide. Malignant's the stuff that's more concerning. Rapid growth, high mitosis rates, undefined borders. You can see from the schematic diagram, it would be a little bit more challenging as a surgeon to come in and remove this. You probably would be able to remove it, but in this situation, they may end up going with like a hysterectomy on this patient. They would take kind of everything out because they don't know exactly how far it's gone. It invades the local tissue. It doesn't stay contained. It's poorly differentiated. Let me explain that. If you look at this cartoon histology, this doesn't look anything like our smooth muscle myometrial layer. Right? We've got some areas of necrosis. We have very ill-defined, poorly differentiated tissue. And metastases are very possible. And we'll talk more about metastases, but usually when a cancer is going to break off and metastasize, it's going to find a vascular supply to get into and then go downstream into the lymphatics and go downstream, or it'll get into body cavities and it'll kind of move around on serosal lining of tissue. Okay, so metastases are definitely possible, and we call these cancers. Well, this tissue is extremely well vascularized, so the concern is if it's malignant, has it made it into the vascular system? Is it already kind of circulated throughout the body? And then we're going to talk mechanistically on the clever ways that cancer is able to metastasize and go downstream and then invade other tissues. Okay. Questions? Okay. So our terminology as we walk through this is neoplasia, or a new growth. And these neoplastic cells, they're said to be transformed because they continue to replicate outside of regulatory cycle boundaries or influences that control normal cell growth. So you go to the dentist and they're like, hey, stick your tongue out, and you're like, ah, and they grab it with a 4x4, and then they're like pulling it to one side and lifting it up, right? What are they doing? Those of you going to be dental hygienists, I mean, what are they looking for? They're looking for mouth cancer. It's so prevalent these days, cancer, that everybody's going to be checking for it. And so here's an oral neoplasia, right? And a lot of these are benign, so they're actually relatively easy to remove. But you want to catch them early so that they don't become malignant and they don't go someplace else. Some other terminology that I want you to write down in this white space are a couple of terms, and I'm going to write them here. Anisocytosis. This one means cells of unequal size. So you get variations in cell size. Popliocytosis. These are abnormally shaped cells. And then hyperchromatism. This is an unusual number of cells that are dividing. These are three characteristics that would be viewed histologically. They would give you a clue that that oral neoplasia was malignant. So they come in, they take a biopsy, they may not remove it, or they remove it and they send it out for analysis, which is often the case. And then the pathology report comes back, and they're looking to see, do you have characteristics, unequal cell size, or abnormally shaped cells, or do you have an abnormal number of cells that are exhibiting hyperchromatism, meaning that they have a lot of mitotic figures present and they're dividing on a continuous basis. And these would be biopsy data that would come from the pathology from that oral neoplasia after they removed it. Or if they took a lesion out of the skin, they sent it out for pathology and they gave you a report back. It's not in you anymore, and we're worried because it came back cancerous. It's a good thing we got it out. Let's just make sure it doesn't come back. Does that make sense? So these are the kinds of things that we're going to be looking for. And some of these terms we'll see pictures of histologically a little bit later. But I wanted to introduce these concepts now so that you could be thinking about them as we move through the lectures. Okay, so some more terminology. Oftentimes cancer is going to be defined based upon the type of tissue or where it's found. Right? So we've got a carcinoma, and the carcinoma is transformed epithelial cells. Transformed epithelial cells, often skin. Okay? And this upper right image of the nose is a squamous skin carcinoma. So a squamous skin carcinoma is of the squamous epithelium. And that's essentially what it would look like. An adenocarcinoma, usually glandular tissue. Glandular tissue. So the H&E picture on the lower left, that's a adenocarcinoma of the prostate. So adenocarcinoma of the prostate gland. So these are going to be normal prostate gland cells here. It's kind of the darker circumference. Look at this one. Instead of having sort of a normal margin surrounding the opening of the gland, look at how much this is proliferating. You see how they're, same with this one. Same with these over here. These are all normal in here with the nice purple border that's, equal width all the way around. And then these guys, look at how extended that glandular tissue is. Okay, adenocarcinoma of the prostate. A sarcoma. Sarcoma is transformed connective tissue from the embryonic mesoderm. And I don't have a picture of that here on this slide. But a leukemia is a cancer of the blood or the bone marrow, and so that's a blood smear in that right side middle. And then a lymphoma is a cancer in the lymphatic cells of the immune system, usually a solid tumor of lymphoid cells, so in the lymphatic circulation. And the picture on your lower right is an arm, and so this is a lymphoma that's sitting inside of the lymphatic tissue in one of the lymph nodes in the forearm, which it actually looks kind of like a calf muscle, but it's actually the forearm, right? That's how swollen it is. And then the last one on the list, on this slide that I don't have a picture of here, is a carcinoma in situ. So these carcinomas in situ are found in places like skin, breast tissue, bronchus, cervix, esophagus, in the oral cavity. And the carcinoma in situ is an early form of cancer that's defined really by the absence of tumor cells, usually before it goes into the basement membrane. So if you back up to this picture here, a carcinoma in situ is going to look like this tissue picture before it breaks into the basement membrane and starts to invade. Okay? So it's kind of that very end of the precancerous phase before it becomes malignant. Follow? All right. This picture, hematoxylin eosin stain picture, this is a polyp. So many of you have, dads or grandpas that are getting scanned. Colon cancer is a little more prevalent in men than it is in female women. And so this is a polyp. And so if you have a colonoscopy performed and there are polyps, this is the intestinal tract, right? And you've got these villi and microvilli that increase surface area. And as these folds take place, this is actually tissue that's turning over on a regular basis. Intestinal tissue, like your skin, regenerates and then sloughs off. You with me? And so this is a colonic polyp, or a stalk, that's replicating at the basement membrane, and it's growing abnormally out of control. And so this is what you would see histologically. They would take a biopsy of this area, and then you do histology on it, and you're confirming that there are polyps. And this is a glandular tumor, so it's an adenoma, and it's projecting into the lumen of the intestine. At this stage, it's not dangerous per se, but the problem is if this it becomes invasive, it breaks through the basement membrane and then gets into the vascular supply, you can have colon cancer that spreads. And it can go from the colon to other abdominal tissues. Okay, or it might make it to the liver. Okay. So, some examples, and now I want to talk a little bit about some of the mechanisms of how these cells become cancerous, and we'll talk about some additional terminology. So, these cancer cells are normal human cells. They're normal cells out of you and I, and cancer is not contagious. If you visit a cancer patient, you can't catch cancer. You can't contaminate somebody with cancer. Okay? So why, when I visit cancer patients, are they wearing masks, or I need to wear a mask? Well, and we'll talk about that a little bit more on Wednesday, but if you're treating cancer patients with chemotherapy agents, chemotherapy is just a terminology that means chemical therapy. So you give them drugs, chemicals. And these chemicals are basically poisons. And they have a variety of different types of poisons or chemical agents that they like to use, oncologists. And the basic concept is you kill off the cancer cells, and you're going to kill off some of your normal cells as well, including some of your immune cells. And you try to kill the cancer cells fast enough that you can come off of chemotherapy and your healthy cells recover, and they can help fight the cancer cells, and the cancer cells die. But if you give a chemotherapy agent and you suppress the immune system, now if you have a visitor that's got a cold or a flu, that's very dangerous to the cancer patient. So that's what they're worried about transferring. They're worried about transferring regular colds and flus and viruses and fungus that you and I battle on a daily basis because we're healthy, And with a chemotherapy patient, that whole immune system that we just got done learning about is completely compromised. So that's, another myth out there is, oh, I don't want to, I'm not going to go visit so-and-so, I don't want to catch anything. Actually, you're more dangerous to them than they are to you, okay? So they're not contagious. So how do cells become cancerous? Well, they become transformed, genetically speaking. We'll talk about this probably more on Wednesday. But normal cells, the way that normal cells operate is they operate with what's called contact inhibition. So if you have a petri dish, okay, and you're going to grow cells in it, and we do this in my lab all the time, not cancer cells, but let's say you're going to grow cells in this petri dish. Once these cells reach the edge of the flask, they start growing in this direction, and they stop growing because they're touching something. It's called contact inhibition. Once they fill the whole dish, the bottom of the whole dish, they become growth arrested. They stop growing. So the analogy would be you have an incision or a wound, and the fibroblasts come in and they start to replicate, and once they fill the space, they stop replicating. That's how it's normally supposed to happen. That is called density-dependent inhibition, or what we refer to as contact inhibition. Okay? So they kind of know when to stop growing. Cancer cells don't do that. What they'll do is they'll grow and fill this whole dish, and once they fill the whole dish, they'll start actually growing on top of themselves. Okay? And they'll grow to such density on top of themselves that if the vascular supply that supplies the tissue can't keep up with the rate of growth, they'll be oftentimes in the middle of the tumor a necrotic core of dead tissue, because the diffusion distance of oxygen is about 250 microns in tissue. And so you need blood vessels to actually supply the growing tumor. And we'll talk about this, but one way to combat cancer is to block blood vessel formation. So you basically starve it. Okay? But cancer cells are not contact inhibited. That's the word autonomy. They act on their own. Autonomy is a word that means, self-regulating. They just do whatever they want to do. Okay? No rules, no regulation. They've lost this anchorage dependency or this contact inhibition. So both of these refer to the same thing, anchorage dependency or contact inhibition. They've lost that. They don't have that anymore. They're immortal. What does the word immortal refer to? Okay, so this means that they don't ever stop dividing and they keep replicating, and you don't have the ability to hit the pause button. And so they're dividing on a continuous basis, and that's a cellular term that we refer to as immortality. And we'll touch on here in a minute telomere length that has a lot to do with this. Okay, I'll introduce the concept right now. So cells that replicate have on their DNA, they have essentially bumpers, and they're called telomeres. And there's an enzyme known as telomerase that helps to lengthen the telomere. And the reason that telomeres are important is they protect the integrity of the main coding part of the DNA. And because replication of DNA is actually very aggressive, I mean, you take DNA, you pull it apart, okay, and then you allow base pairs to anneal to their partner, and that activity is fairly aggressive. And so you have the ability to preserve the quality of the DNA by these little telomeres, and as a cell gets older, its telomere length shrinks. So if you look at cells, replicative cells in a 70-year-old patient, the telomeres will be much shorter than replicating cells in a 20-year-old patient. Except if you look at cancer cells, they have very long telomeres. And so once the telomere is too short, the cell stops replicating. So what cancer does is it lengthens its telomere to allow for more immortality, more replication. In the cell world, the replicative ability is mortality. So they're immortal. They have an unrestricted capability to divide. This terminology of anaplasia. So anaplasia is a loss of organization. A loss of organization. And then pleomorphic is variable shape and size. So now these cancer cells are growing and they're no longer anchors dependent. They become anaplastic, they become pleomorphic. So they've got a loss of organization and they've got variable shape and size. I should also add on anaplasia, it's loss of organization, and there's a second characteristic, which is an increase in the size of the nucleus. Why do you think that's important if you're a cancer cell? A large nucleus inside the cell is typically indicative of what? What's that? More DNA. Why would you need more DNA? What are you going to do with it? You're going to constantly divide, exactly. So the larger the nucleus, presumably the more metabolic activity or more mitotic divisions that are taking place. That's a characteristic, another characteristic of anaplasia. So these cells become immortal. They haven't always been immortal. And they do this mechanistically through this enzyme known as telomerase. And so I want to back up a little bit to some of our stem cell work that we've talked about in previous lectures, where if we look at a normal cell, and this is age, right? Cell division's going to the right over time. So a normal cell, as we get older, loses telomere length. And at some point, it turns into a state which is known as growth arrested. We no longer have the capability of dividing that cell. Now, in you and I, in vivo, this is typically somewhere between 70 and 90 years of age. There's all these anomalies, like these patients that lived 105. And so, of course, the fountain of youth research that people are always exploring is, well, what if you could lengthen telomeres? Well, in you and I, this is 7 to 9 decades where these cells can divide. If I take fibroblasts from you and I culture them, in about 12 passages, they will poop out. They won't divide anymore. 12 passages means I grow them until they're contact inhibited, then I pull the cells out, and I separate this population into 4 flasks, so that has more space, and then they grow, and as soon as they hit contact inhibition, I collect all the cells, and I put them into 8 flasks, and then 16, and then 32. So if I do that 12 times, they stop growing in culture. They become growth arrested. So our normal cells cannot go on forever. Now in us, that's an artificial environment because that's on a bench top, right? So in you and I, it's not 12 divisions, it's like 7 to 9 decades, fortunately. But if you look at germ cells at the level of the gametes, again, they preserve their telomere length as long as fertility is there. Stem cells, our stem cells decrease, but they have a longer lifespan. And then look at what interestingly happens when there's a mutation on telomeres. Cancer cells start lengthening their telomeres and make them longer. And that's how they achieve this immortality. So one thing that was interesting, this is a coffee table magazine, and the date is February of 2011, so this is a while ago. But I found this article fascinating, and the reason I found it fascinating wasn't because of this 2045 is date to become immortal. And if I'm still teaching this class in 2045, which is probably not going to be happening, we'll see if this Time magazine was correct. But I actually pulled this article for this particular article. And this article, and I boxed it in red, and This guy's not from Flagstaff, but he looks like he could be. In 1985, not this individual, but Dr. Elizabeth Blackburn, who was at UC Berkeley, and her graduate student, Carol Greider, and Carol's now at Johns Hopkins University, discovered this new enzyme called telomerase. So telomerase was only discovered in 1985. Okay, so it's a relatively new discovery, and what was interesting about their discovery is they were talking about the utility of it. And it lengthens these telomeres and it prevents chromosomes from being whittled down as cells repeatedly divide. So as a result of these studies, they shared the Nobel Prize. These two women shared the Nobel Prize in 2009 in physiology or medicine with another telomere researcher, collaborator, Jack Szostak, and that's a picture of Dr. Szostak at Harvard Medical School. And so they ran an experiment, and you can read it here on the text. This experiment was, so this is a Nature publication from Harvard Medical School, Johns Hopkins, Nobel Prize, but Time Magazine is describing it. So we don't get our science from Time, but they did a really nice job of showing a picture of Jack and characterizing this, and so I thought it would be interesting for you all to see it. Every time a cell divides, its telomeres get shorter, and once a cell runs out of telomeres, it can't reproduce anymore and dies. So they got that accurate. But there's an enzyme called telomerase that reverses this process. It's one of the reasons cancer cells live so long. They got that right too. So why not treat regular non-cancerous cells with telomerase? Right? Can we live longer? So this is in November of 2010, because this was a February publication. Researchers at Harvard Medical School, Jack, announced in Nature, which is like the premier scientific journal out there, that they had done just that. They administered telomerase to a group of mice suffering from age-related degeneration, and the damage went away. The mice didn't just get better, they actually got younger. So we have treated mice with telomerase and have been able to reverse the effects of aging. So what's going to happen by 2045? I have no idea, but you guys will experience it. Probably be impacted by it. Okay? And if you figure it out, maybe you'll give me some of it, because I'm going to be really old. Okay. All right, let's talk about this situation. I want you to turn to your partner and talk about the situation. You've just been told by your patient, you're the physician, your patient says that he has a lipoma. He's really concerned because his sister was diagnosed with a liposarcoma, and it sounds like he has the same thing. So what do you tell your patient? Okay, go ahead and talk amongst yourselves, and we'll come right back. All right, any thoughts? Any thoughts? Be fine. Don't worry about it. Why?
Because the oma is benign and the sarcoma is malignant.
Yeah, Generally speaking, this nomenclature still holds true. I think there might be a couple of examples that I've run across. But if the suffix is oma, it usually refers to a benign lesion. And if the suffix is sarcoma, then it's a malignant lesion. Okay, just from a nomenclature standpoint. Okay, let's talk a little bit more about these terms, anaplasia and pleomorphic. I wrote them up here and I described them and gave you definitions, but I want to show you some of these examples. So what does this tissue in the upper right look like to you? Upper right. Hematoxylin stained section. Looks like muscle, I would agree. What kind of muscle? Skeletal muscle, I completely agree, well done. That is normal skeletal muscle up in the right. Normal skeletal muscle. Down in the lower right, I'm going to dim this. Is it a little easier if I dim this? Okay. In the lower right is a lesion of skeletal muscle. And this particular lesion is an anaplastic tumor of skeletal muscle called a rhabdomyosarcoma. RHABDOMYOSARCOMA. So it's a sarcoma, a rhabdomyosarcoma. And so what I want you to point out to me is some of the features, both in skeletal muscle. I want you to tell me what are some of the features, and use terms like anaplasia, it's defined there, and pleomorphic, and it's defined there. And then I want you to tell me, is that rhabdomyosarcoma, is it malignant or benign? And tell me some of the rationale as to why. Okay, so you work together, and then we'll come back.
Oh, yeah, just like the characters. Yeah.
You guys are playing forensic pathologist right now. Okay? So the surgeon cut out tissue, sent it out for pathology, and the family is waiting every day for a phone call from you, right? You'll call their physician, tell them the results, and the physician will call the family. But this is the kind of stuff that they would look at. Now, I already told you this is a rhabdomyosarcoma, but you can hopefully see there's monster differences between normal skeletal muscle and an anaplastic tumor of skeletal muscle. All right, so let's hear a couple of your, again, don't worry about sounding elegant or not elegant. I'm more interested in you kind of being able to tell the story with the pictures here of what you'd be seeing. So go ahead and use the terms that are on the screen if you want. Go ahead, DJ.
I'm seeing some aniso and kelocytosis.
Okay. Aniocytosis. Aniocytosis. Cells of unequal size. I would totally agree with that. I mean, look at this monster, right? Compared to this guy right here. So that's that aniocytosis, the top one that we talked about. Cells of an equal size. Very good. And then what was the other thing you said?
The one below it, is it?
Poikilocytosis. Poikilocytosis, abnormally shaped cells, right? I mean, what the heck is that, right? I mean, this is what they're supposed to look like. And look at this guy. Totally agree. Okay, what else? Well done. Hyperchromatism, right? Where's the hyperchromatism?
Massive density.
Yeah, look at how dark the nuclei are. You guys see that? And then look at the nucleus of these guys. Now, what can you say about the size of the nucleus between the two? Do you use a fancy word to describe the size?
Bigger.
Bigger. It's not as fancy as I wanted, but yes, I would agree. It's enlarged. Anaplasia. Increase in nucleus size. And then it also is a loss of organization. So anaplasia has these two features associated with it, and I'm seeing all of that right here. Are you? And then, of course, what about this last one? Can you guys appreciate the variable shape and size of these former skeletal muscle? Does this look like skeletal muscle? Is it well differentiated or poorly differentiated? Poorly differentiated. Are you worried about this tissue metastasizing and going somewhere else? Absolutely.
Is there any specific difference between the pleomorphism and the aniocytosis?
So variable shape and size on pleomorphic and unequal size, they're kind of two terms that really are characterizing almost the same thing. But this one's saying it's variable, and the other one's saying they're just unequal. Okay? So you're going to have big and small when you've got unequal sizes, and variable shape is referring to if it's elongated, it might be circular.
Okay.
Does that make sense?
Yes.
Okay. So let me rephrase that. Yeah. So that now I understand why you're struggling. So variable shape is the skeletal muscle bundle is kind of like a circle. Okay. So look at the circle here in cross section. So it's saying variable shape. You might have some circles, but you can have this a long one, right? So I'm trying to even find one that looks relatively similar to. I mean, this one's pretty close, okay, in shape, right? But this is definitely, and this is similar. This is definitely similar, but it's unequal, so it's too large. Does that make sense, the difference between the two? So pleomorphic is variable shape where it may not be a circle, it may be oblong, right? And then we've got our poikilocytosis, where we've got the unequal size. I'm sorry, anocytosis, right? Aniocytosis, the unequal size, big, small. So circle versus oblong, right? Pleomorphic, and then aniocytosis is large versus small. Does that help? Okay. Is this sinking in? There's a lot of information on this slide. Let me repeat that. There is a lot of information on this slide in these terms. You guys catching that hint? All right, good. Yes, in the very back. Hyperchromatism. Yeah, so hyperchromatism is you've got an increased presence of mitotic figures. So you've got an abnormal amount of cells dividing. There's a lot more DNA present. In other words, the nucleus has more purple in it on a hematoxylin-eosin stain slide. Okay. Let's talk about tumor markers, and then this is where we're going to end for the day, because this is a lot of information, And the danger of this lecture is throwing too much of this new terms at you. I mean, there's so many definitions here that we've had on that last slide. So this is the last one that we're gonna do for the day, okay? But we've got a solid 7-8 minutes to finish it out, so don't feel like we're rushing. Tumor markers. So what the heck are tumor markers? Well, these are markers that typically give you an indication that there's something going on cancer-wise. And some of them you're very familiar with, you didn't even realize, because you've heard about it. So they're typically found as a marker on the plasma membrane, that's what the PM stands for, circulating in the blood. It could be in the spinal fluid, or they could be in the urine. And we're going to do 2 examples. So we'll be fair on the sexes. We'll give a female example and a male example. So let's talk first about HER2. And it's a female example. It's not why it's called HER2. It actually stands for human epidermal growth factor receptor number 2. Human epidermal growth factor receptor number 2, abbreviated HER2. It tends to be convenient that it's a marker for breast cancer. Okay? But if you look at this diagram, you can see that there are tumor markers all over the body. We've got CA-125, CEA for lung cancer, AFP for liver, PSA, which is what we'll talk about for prostate, AFP or HCG for testicular cancer, ovarian, CEA or CA-125. So these markers, here's the HER2 on breast tissue. These markers are found like on the plasma membrane of the cell. They're found in the blood circulating, or in the spinal fluid circulating, or in the urine. And the way that we use these markers is to give us an indication if there's abnormal replication of cells happening. Okay? So, for example, in HER2, we've got a patient on self-exam finds a lesion or a nodule. There's a history of breast cancer in her family. She's a little concerned about it. It's a mammogram. In the mammogram, these nodules will light up, a white highlight on an X-ray black background. The oncologist may look at that and say, well, I want to get a biopsy because I want to know for sure what we're dealing with, okay? It's inconclusive. So they'll come in, they'll do a biopsy, they'll send it out for pathology, and they'll do an immunostain for HER2 levels. And if HER2 levels in that nodule are higher than normal tissue, then they're going to say, I think we need to take the lesion out. We have an overproduction of cellular mitotic divisions. We're getting higher expression of HER2 in this particular area. That tells me that this is replicating out of control. Let's get rid of it. Does that make sense? PSA, prostate-specific antigen. So what does HER2 stand for? Human epidermal growth factor number 2. PSA stands for prostate-specific antigen. If you ask me on the exam, what does HER2 stand for, I won't be able to tell you. Okay? If you ask me what PSA stands for, I won't be able to tell you. Or Ryan. Those are pieces of information that I want you to know. Okay? Yes?
If it's human epidermal growth factor receptor, then why is it found in like a deep nodule? If it's not like part of the epidermis.
Oh, because it's expressed in a lot of different tissues.
Okay, that's
It's
just
not
because they
just
found it.
it's not just expressed in breast tissue. It's expressed on other epithelial tissue as well.
Okay, so is the epithelium in the breast?
What's that?
So you said that like they would take a sample of the nodule or like the that's like a deep tissue.
It's a deep lump. Typically, breast cancer is going to be deep into the breast tissue.
Yeah. So I guess I was.
So
just
why is it an epidermal marker?
Yeah.
Yeah. Because when it was discovered, there's a molecule known as human epidermal growth factor.
Yeah.
That binds on receptors that are found on epidermal tissue.
Okay.
and it's the same that's found in breast tissue, so it has the same name, even though it's not epidermal tissue.
Okay.
Yeah. It's a reasonable question. Yeah. So, let me further explain. Human epidermal growth factor. Human epidermal growth factor is a signal to say divide. So, what that means is that breast tissue has more receptors on it to receive human epidermal growth factor and cause division. That's the mutation. You with me? So if there's X amount of human epidermal growth factor floating around the body, that breast tissue that has twice or 3 times or 10 times as many receptors is going to respond tenfold to that growth signal, and that's why it gets bigger. That's the problem. Okay?
Are those the only 2 markers you want us to know on this slide?
The only 2 markers I want you to know on the slide are HER2 and then PSA. That is correct. The PSA is for men. Prostate-specific antigen in the blood. A little easier for men. You don't have to have a biopsy necessarily, initially. But PSA level. So as we age as men, the prostate does enlarge. And so PSA levels go up naturally. So if you're looking at a chart, okay, cool. If you're looking at a chart, is that too low? You guys see that? And we're looking at time here, and we're looking at, or so let's put age, right? And we have 20s, 30s, 40s, and then 50s. So you might see, and this is relative PSA in the blood, you might see a chart that kind of does this as you get older, because the prostate in men actually does enlarge as you get older. So it's important to get PSA levels somewhere in this range to know, are you normally here? Because what you need to understand as a male is you hit the age of 50, and if your graph is doing this, and you're normally here, and this is the normal level, now they're concerned, and they're probably going to call for a prostate biopsy. Same thing, prostate-specific antigen. It's an antigen that's expressed on prostate tissue, so as the prostate gets more massive, you have more PSA levels that show up in the blood. Okay? Well, the aging process in men, the prostate does get bigger. And so that's a natural aging thing, but prostate cancer outpaces that normal age increase of the prostate. So that's why we monitor men past certain ages, depending upon history in their family. Usually it's 50 and beyond, it could be earlier. They're just trying to get a data set to know where do you normally fall on the curve so that we know if we have a problem. Okay? So the uses of tumor markers. Screening, diagnosis, and then we can track disease progression. So you can look at PSA levels, and if PSA levels come back down, you know that therapy is actually working. Does this make sense? Now, the more sophisticated therapeutics are starting to use these markers. And that's where the field of oncology is going, is we're getting much more sophisticated on being able to target with chemotherapy, targeted chemotherapy to certain tissues, rather than just giving broadly to the whole system a poison. So now you can start directing your chemotherapy, or in some cases immunotherapy, because you actually are able to hone in on certain tissue types. There's a question here, and then we're done. Yeah?
So PSA is like a surface antigen on prostate cells?
Well, it's released into the blood.
Okay.
Yeah, it's released into the blood. But the prostate cells manufacture it.
All right.
Okay, that's all we have for today. I'll see you guys on Wednesday, and we'll pick it up right here.